Good afternoon, everyone. I think we might make a start. Welcome everyone to this afternoon's presentation. This is our first one of our Perspectives for the year, and I'm delighted that you're here. So my name is Jenny Phillip, and I'm the Chair of Palliative Medicine at the University of Melbourne. And it's on behalf of Nexus Research Group that I'm welcoming you here to this Perspectives event. Palliative Nexus is, as I said, a research group whose goal is that all people with advanced illness receive high quality palliative care that's equitable, timely, and delivered as a standard of care underpinned by high quality evidence. To begin, I wish to acknowledge the traditional custodians of the land. I'm on the land of the Wurundjeri people of the Kulin Nations, and I pay my respects to elders past and present. And I also wish to acknowledge the owners, traditional owners of the land across the different areas where you all are this afternoon. You'll remember, and just as a sort of a reboot, because it's a new year and all those things that go with a new year, that Perspectives is a broadcast series that we conceived as a way of connecting and staying in touch and staying up to date back in lockdown, and we have kept it going because it's proven to be, I think, popular and a great way to hear great speakers in our field and in associated fields. And again today we are honoured with another such great speaker, Professor Mai Krishnasamy. So Mai is Professor of Cancer Nursing in the Department of Nursing at the University of Melbourne. She's the Honorary Professor in the Department of Health Services Research at Peter MacCallum Cancer Institute, and she's Peter MacCallum Cancer Centre, and she's the Research and Education Lead for Nursing at the Victorian Comprehensive Cancer Centre Alliance. And her research is very much also focused on areas of equity and access to cancer supportive care, particularly for older adults with cancer and for people with poorer prognoses. She has been highly successful in her career and has secured squillions of dollars for funding for the grants and the projects that she's leading, and she has published very widely. And I feel quite honoured that she's here today, and also honoured to call her a friend. Today, Mai is going to talk to us about value-based healthcare for people with cancer. Thank you, Mai.
Thank you very much, Jen, and it is absolutely my honour to be here. Thank you very much for the invitation to come and share some thoughts with you and with everybody who's online around some concepts of value-based cancer care today. And before I share my slides, I too would like to acknowledge the traditional custodians of the land on where we all meet, wherever lands you're on, and I'd like to pay my respects to elders past, present, and emerging. So Jen, thank you very much for the opportunity to be here. I will share my screens, and then for the next sort of just under half an hour, share some thoughts and ideas with people around this concept of value-based healthcare. I'll just bring my screen up and do that, and then make sure that I've got, there we go, great. So what I'm going to talk about are some concepts of value-based cancer care for people, but really to begin the talk by thinking about, what do we mean by value-based care? And I'm certainly just bringing one perspective today. It's a huge topic, and I really want to just share some thoughts that have influenced some of the work my colleagues and I have been doing, but recognising that there are many different definitions and perspectives on value-based care. So I suppose I've been really influenced by and want to sort of just talk on this paper that was published by Michael Porter and Thomas Lee back now in 2013, which was called The Strategy That Will Fix Healthcare. And I love this first line. Back in 2013, they said, in healthcare, the days of business as usual are over. And gosh, if we didn't realise that before the pandemic, we certainly realise it now. But what was really interesting for me in this paper was the way in which Porter and Lee, back, almost over a decade ago, proposed this definition of what they meant by value-based care in the context not just of cancer, but value care more broadly. And I'll come and talk a bit more about some of the cancer experiences in a little while. And what they were saying in that paper was that in healthcare, sort of the overarching goal for those of us delivering care and caring for people and generating new knowledge in the way we care for people. As well as for clearly, of course, for the patients and family members and community members themselves. That the issue around value must be about improving that perception of value for patients, where value is defined as health outcomes that matter to people relative to the cost of delivering that care. So improving value requires either improving one or more outcomes without raising cost, because actually we're cost constrained and at the moment painfully aware of that in our healthcare systems, not just here in Australia, but of course globally. Or it's about lowering costs, but importantly, lowering costs without compromising quality and outcomes. So, you know, their sort of message really was failure to improve value in all of that means around cost, but clearly what matters to patients means failure as a healthcare system. And then we saw ASCO, the American Society of Clinical Oncology, who've been writing a lot about value. And this sort of talks, I think, in a way to some of the challenges of how we all bring different perspective and lenses to what we mean by value. And back as early as 2009, ASCO produced a guidance statement on the cost of cancer care. And really since then, the perspective of value has almost unilaterally been around that issue of cost. So delivering care and being able to constrain the cost. And even though that conversation since 2009 has become much more nuanced and more sophisticated, even as far as the latest sort of documents coming out from ASCO. You'll see here this document in 2020 around looking at net health benefit for people with advanced disease. The focus was still very much on cancer drugs and the benefits and side effects of those and the costs of delivering care, as demonstrated through large randomized controlled trials. And although, of course, that is critically important, it really didn't create a way of helping clinicians think about, well, how do I think about and deliver value-based care in the context of the people I see in front of me? And this paper, published by Daniel Goldstein back in 2016, I think touches on some of the challenges of restricting conceptualization of value-based care to cost by saying, you know, how should these guidelines around sort of the economic literature be used by those practicing physicians or the health professionals at point of care delivery? So how do concepts of value intersect with the ethics of serving an individual patient as a physician? How does a physician's responsibility to an individual patient tie in with economic responsibility to society as a whole? So how do we marry, you know, ongoing delivery perhaps of low value care, when actually what we want to do for the people in front of us is make sure that they've had the opportunity to know about and have the opportunity to be involved in discussions about the myriad of treatments that may be open to them. So the construct of value-based care as a financial issue has been helpful in bringing that to the fore. But it's not really helped move the conversation forward in terms of how do we actually build a system of healthcare that is driven by a concept of value. And so back to Porter and Lee, this is work by Michael Porter that he published as a PowerPoint presentation that is available online, and he presented this in 2014, where he started challenging early on that notion of actually we have to think beyond value-based care in the construct of just money. Of course, money is critically important, but if we really want to build a system that is driven by the concept of value, we have to think about a fundamental restructure of how we deliver care and how we think about end-to-end costing and end-to-end pathways of care for people. You know, and he was saying then that in 2014, what actually we have in the system of care is a legacy of medical in its broader sense science, of a legacy of organizational structures that are no longer fit for purpose, and they're certainly not now, given the crisis in the health system. management practices and payment models that are actually obsolete in terms of the currency of the problems that we face. And what he was saying is, actually, if we keep just sticking new things, or a new intervention here, or a new role there, or a new sort of way of thinking about things here, but not actually taking that system level focus to saying, how do we fundamentally change the healthcare system so that from point of entry, whether that's in primary care, all the way through to end of life or survivorship, wherever it may be in the context of cancer, actually we're not going to make a fundamental difference. So what he was saying is, if we think about what we've been doing, you know, in terms of a value-based system, what we've tried to do is put magic bullets in. And what we're all painfully aware of, and interestingly, in Porter's work in 2014, there's a silence almost on implementation science that we now are garnering understanding of and developing expertise in, to know that actually you can't just put something new in. You need to understand the context within which you're putting it in, and you really need to understand what are the barriers and enablers to that. And perspectives around value and what constitute values are critical barriers and enablers to whether we can get things into a system and whether we can make them stick. So he talks about this issue of, you know, there's been a lot of talk about turning patients into consumers, but actually we have very little understanding of what that's meant around the efficiency of care from a cost point of view. And critically, we have very little understanding as yet of what that's meant for experience and outcomes of care for patients, although that literature is growing. Another sticking plaster that he talked about was, you know, not addressing root causes of things like low value care, continuing to do things because we're too busy to stop, or because we've always done them that way, is an actual, you know, real deterrent to value-based care, which we're all aware of. That issue of a real focus on reducing errors, although critically important, doesn't actually help us think about a redesign of systems. So we look at errors and we look at root cause analysis, and we try and fix some of those things for the problem in front of us. But the issue that we're being challenged with the value-based agenda is looking upstream and downstream. You know, how do we actually have influence on the system from its entry to exit, to actually rethink about how we deliver care and the things that we need to understand that need to be in that system to genuinely deliver value, and value for who? And I'll come on to that in a bit in a moment. The other piece that I really want to call out that, you know, Porter was writing about in 2014, and we see a huge plethora of literature around, particularly in my professional discipline in nursing, is this issue of care coordination, or navigation of care, as we're now calling it, with this sort of sense that, you know, the panacea for all ills is to throw more care coordinators in. And although, of course, critically, patients need people to help them navigate through a really complex system, the argument is actually what we need to do is try and fix the system, not put people in to try and fit the gaps that are in the system that we have. And that's a critically important part around the equity piece that Jen mentioned earlier, to make sure that the system works for the most disadvantaged people. We really need to fundamentally think about who are we creating value for, and who do we measure that. The other issue, of course, with sticking plasters is we put an electronic medical record in, going, this will be the panacea for all our ills. But again, as with electronic medical records, and similarly with things like digital collection of patient-reported outcome data, we need to understand whose data is in there, are in those digital databases. Because if we use those to build our value-based system, we build them with knowledge of only the people whose data is in there. So the question for us from a value-based agenda is, whose data is not in there, and how do we start to get those voices in there? So it's a complex piece, but I want to try and move into a bit more conversation on palliative care before giving you an example of how we've used some of these constructs of value-based care in some of the work that we've been doing. So this is around economic benefits of palliative care, but of course, the dialogue and the narrative in palliative care has been much more sophisticated than in the acute end of cancer care, around understanding economic benefit as something that has to be understood around the value and benefit to patients. But we do know, and research in palliative care consistently tells us, that people who receive palliative care compared to those people who don't, have better experience of care, they have better outcomes of care, and actually the care around them is able to be more efficient. So you have this reduction in admissions to intensive care and ED departments. And so there's a real opportunity, I think, in the acute cancer care world for us to turn our vision to see the philosophy around palliative care and think about how do we start building value around, yes, efficiency and cost, but actually those outcomes that really matter to people, because at the end of the day, that's the business that we're in. And I want to call out Jen's work here, that leading the Care Plus study, which actually is a fantastic example of thinking about restructuring the system, taking interventions that are proven to be efficacious and building implementation strategies around them that allow them to be tailored into different systems of care, so that they allow the system to begin to reconfigure how it thinks about where palliative care fits, how people get referred there, when they get referred there, what are the trigger points, and actually brings a conversation with people in the system to think about how this fits well. And the data from that study is incredibly positive, and I really encourage you all to have a look at that. But I really wanted to call this work out, because I think it's beginning to show us the way of how do we integrate what matters most to patients and their family members, and indeed the multidisciplinary healthcare team, but do that with a lens that allows us to think, actually, does the way in which we configure care allow us to deliver this to people? Late in the day, going back to the ASCO papers, if you remember, that work started in 2009. In 2024, they have just published this new position statement within their value-based framework that says, that recognises the importance of shifting beyond that purely financial perspective on value to looking at social, economic, and environmental factors that influences perceptions of cancer care, its outcomes, and its value. And one of the things I really like around one of the webinars that has come from this conversation is, that this rhetoric around, or this language around the fact that along the way, value-based care has inspired new perspectives, or is shifting to a new perspectives, with questions about quality, particularly about what constitutes quality from the patient's perspective is moving. So some of those really important components of patient-centered care and shared decision-making, attention to things like financial toxicity, logistical issues, and transportation and work disruption. And I saw this new term today called time toxicity. So the toxicity of time for people to come to treatment, to take part in treatments, which is a really interesting paper that was published in 2023 there by Gupta. This sense of really taking the breadth of perspectives of what are the things in a system of care that can influence people's perception of value. The issue, of course, around psychosocial needs. And then this issue of that many of these things affect not only the patient experience, but if we attend to these other things, so the experience of care, financial toxicity, shared decision-making where people want that, it actually also improves clinical outcomes. And we know that from a lot of the work, particularly from work in palliative care. I think one of the problems, though, in the acute care system, and the example I want to bring up is around screening for unmet supportive care needs, and I'll talk about that, is actually we lack evidence to be able to show what are some of those clinical outcomes, both at a patient level, but also importantly, what are some of the system level benefits. And so I want to talk in the time I have left, and I will talk at a high level. This is a big program of work, and I'm aware I don't want to go over time, but I want to touch on some of these concepts around how do we understand value, and how through a better understanding of a breadth of what value means, we can actually start to generate data that helps us advocate for that fundamental change in how we structure and think about care delivery. So the Value in Care study, which was funded by the Victorian Department of Health back in 2018, really was a call to arms from the department to say, actually, we really need to rethink about issues of supportive care and cancer, and really try and demonstrate its value in the system and also to patients. A really big shout out to my colleagues on this project, Amelia Hyatt, Holly Chung, Carla Goff and Ruth Aston, who made this project a delight to be with. And I really want to call out Ruth and Amelia, who were remarkable in some of the social return on investment methodology that I will glibly skip over during this talk. So just some context about where this work came from. The Department of Health in 2009 here in Victoria were ahead of the game and recognised the importance of those supportive care conversations to patients and those people supporting them in the networks. Do you need help with something? Is there something that you need help with to be able to manage this diagnosis, the fallout from treatment, the fallout from the toxicities, the ongoing problems, the communication perhaps about, an imminent end of life? And what over a 10-year period, the department realised was they'd spent a lot of money, around $11 million here in Victoria, but actually there'd been very little traction in embedding and integrating supportive care needs screening as standard of care for people here in Victoria. And so the opportunity for us was to go back and really understand what is happening here. And we'd had a project previously that was called the Supportive Care Refresh Project that had really allowed us to understand that actually people want this. It is something that they fundamentally believe should be a part of care. And so it wasn't going to be enough for us to just go, well, actually, let's just do some new education or think about some new resources and stick those into a system that clearly wasn't able to integrate them for lots of reasons. So we had a big program of work, and I'm not going to talk in a lot of detail at all about the first three aspects. I want to talk about this social return on investment methodology as a new way of us to think about valuing and capturing value of cancer care. So we were really interested in thinking about how do we demonstrate value, and can we actually capture value as a return on investment? So what happens if we convince a healthcare sector or system to invest in supportive care? Does that have a return on investment at a patient and carer level? And really importantly, does it also have a return on investment at a system level? So we did a lot of work. We had these first pieces of work. So we were looking at, do the definitions of supportive care that have been in the literature of a while still hold true? And we had a modified directive Delphi, an international Delphi to do that. We wanted to look at actually, is this construct of supportive care still relevant? Because one of the things we'd heard from the previous work was that supportive care was often seen as an add-on to the system rather than a fundamental concept of care. And people were telling us, actually, this should be the platform upon which all other care is delivered. And so again, we went out and did a huge piece of work around asking people through the Delphi about what they think a model of care should look like that integrated supportive care, and we were able to develop a new framework, and I'll show that very briefly. We then wanted to say, well, actually, if we want to know what the return on investment is for cancer supportive care, it has to be good supportive care. And we had no quality indicators for cancer supportive care. So through a separate Delphi study, we were able to engage with supportive care experts across lots of disciplines and consumers internationally to help us develop a set of quality indicators. And then from all of that work, we went on to do the social return on investment study. So really quickly, that issue of consensus statements, what people told us was, the provision of supportive care is designed to empower and enhance decision-making, maximize tolerance and benefit from therapy, alleviate symptoms of cancer and side effects of treatment, optimize functional autonomy, wellness and health outcomes, and improve coping, self-efficacy and dignity. So that is the value proposition of cancer supportive care. And so we were able to take that and then say to people, if this is the value proposition of cancer supportive care, what does that look like in an integrated framework? Now, I don't expect you to be able to read this, and I've put the reference to the paper at the end, but we had this internationally endorsed, refreshed framework around restructuring the health system to say, if you build the notion of cancer care around those value-based propositions about dignity and coping and shared decision-making, actually what then happens is you build the rest of the care delivery for people upon those propositions. And we've sort of drawn it here linearly, but of course we know that people circle through the system And so things like palliative care treatment, which is in here, and the treatment component might come earlier or later and revised back. But really would welcome feedback for those of you to have a look at the paper and have a think about the framework. And is this something that actually can help us think about how we restructure care and think about the importance of supportive care as something that we offer as the platform for the concept of value-based cancer care. So from that work, that third piece of the work was this issue of quality indicators. There's no point trying to measure the value of something if what you're delivering actually doesn't have high quality. And so we, through the International Delphi, we came up with 16 quality indicators. The top 5 are here. So it's things like actually you've got to ask the questions, and you've got to have a workforce that is capable of asking the questions. What is troubling you? What is distressing you? What do you need help with? How can we help you find that? That you need to be able to document that you need to be able to demonstrate as an organisation that that work is happening, that there are opportunities to refer people either internally, externally. I won't read all of them, but there are 16 of them, and that paper is about to be published, so that we can then begin to think about at a state-based and national level how we begin to have standardisation of access to an equity of opportunity for quality supportive care for people, no matter where they're cared for, no matter who they are, and no matter where they receive their care. So we took all of that work, and in the time that's left to me, I want to sort of try and explain briefly how we took that into what was a very new methodology for me and many of us, this social return on investment, which is a framework that's built on a traditional return on investment and a cost-benefit analysis. And although it uses monetary terms, it's actually about describing value, where it's about value created rather than money saved. So what we wanted to understand was, if we could get quality supportive care into the system for people, what would be the value generated? So we used a forecast evaluation because we had a fixed period of time, so we couldn't do it prospectively for people. And what we said was, we will work and think hypothetically for a forecast evaluation with a cohort of patients who we know have a really high symptom burden. So we looked at people with lung cancer. And we built a forecast evaluation around value for people who had a prognosis of 1 year and 5 years. We worked with 2 metropolitan healthcare services, one where we knew there was a really established programme of supportive care, and one where there wasn't. And then we defined value activity in our methodology as the implementation of this integrated model of quality supportive care. And as I say, the purpose was to try and understand the value gained. I'm not going to talk to all of this, but we used a 6-step, you can see 5 here, the 6 is implementation, that was outside of the scope of our work. But we used a 5-stage methodology that comes from the SRI network, and the references there, which is a fantastic toolkit around supportive care, where the first stage is around defining the scope of your practice, and we did that through literature reviews, talking to experts in the field, identifying key stakeholders for the SRI methodology, deciding who they would be and how we would engage with them, down through stage 2, where we mapped inputs and outputs. We had a big 3-area of change process where we said, if this is what we want to get to, this integrated model of quality supportive care, what needs to be in place to do that? And then we calculated the cost, the monetary costs of delivering those, and the value generated of all of the aspects of those quality indicators around supportive care that we needed to be in. We did a whole heap of quite complex, and I say the royal we, was really Amelia and Ruth, who looked at how do we do some quite complex economic modelling for our forecast, and then we calculated what the social return on investment was. So just really quickly, and I'm not going to talk to these slides, I just want to show the complexity of some of the modelling. So this was about mapping the inputs and outputs. So we looked at the evidence that said what was demonstrated as delivering value to people and to the system. And then we asked the stakeholders to articulate whether they felt that there were values, so to really to validate those value components. We then mapped the evidence from their narrative, and then we teased out what the supportive care activities were. And I'll keep going through this. Then we looked again at the evidence, we looked at the consultation, and then we looked at, well, what is the outcome of doing that, both from the stakeholders' perspective and the literature? And so we were then able to say, you know, for example, the outcome here of having care coordination is that vulnerable and disadvantaged people get access, equity of access, and their needs are recognised in time, and that's relevant for people at 1 year and 5-year cohorts in terms of their prognosis. And so, again, I won't talk to this. We went through each of these processes, mapping these things out, putting costs in. Some of the costs were quite easy to put in. There were proxies that we could put in. Others were harder, and we had to do some economic modelling, and really then again took those models back to multidisciplinary clinical experts, research experts, policy experts, to check some of those propositions and assumptions. We then put indicators around what happened if we were able to get those quality components in place. And I'm just going through this quite quickly because I want to really give you the tail end of the story. And then we assigned values to those activities in terms of what they would cost if they were there for people living 1 year after a diagnosis of cancer, and for 5 years, and what would happen if those activities or those quality aspects of supportive care were not there. And so we assigned, as I said, these financial proxies to each of those, and then did something which was called putting factors that were associated with the proxy costs, we'd said. So we were not doing things like double dipping and making sure we weren't overestimating costs and over exaggerating what some of the benefits would be, and used a number of these factors called attribution, dead weight, displacement and drop-off, which are really well established in return on investment economic modelling, to make sure that if anything, we were underestimating the value that we were generating. And so just in the last couple of slides, what we were able to do was demonstrate a social return on investment ratio. So for every dollar spent by the health system, what was the ratio of investment back to the health system and patients combined, the health system separately and patients combined. So have a look at this. So this is for the health system and patients combined. For people who live up to 1 year after diagnosis of lung cancer, the combined value generated for every $1 spent by the health sector, if quality supportive care is delivered, is a $9 combined return on investment. For people who live for 5 years, that return on investment increases. So for every dollar the system spends on delivery of quality supportive care, there is an $11 return on investment combined to the health system and to patients. If you split them out, the value for the health system alone at 1 year of dollar invested is a $5 return on investment to the health system. And at 5 years, there's a $7 return of dollar investment to the system for every dollar the system puts in to the delivery of quality supportive care. But look at the patients. So for people living 1 year, for every dollar spent, there is a $56 return on investment for patients. And at 5 years, there is a $64 return on investment to patients. And you can see the value benefits to the cost of investment in each of these. But at a time when the system is in financial crisis, when people are absolutely hammered by financial toxicity, when the cost of living is high, for me, there is something incredibly powerful in this data about the fact that the delivery of optimal quality supportive care results in positive social return on investment ratio generated for health services and for patients. That is, the social value way exceeds the investment. And health service investment in cancer supportive care continues to increase over time. And so there is a clear value proposition here for something that has had $11 million worth of investment and has not been as yet integrated into the system. And so for me, this is a wonderful way and a new way and a novel way for us to think about how do we demonstrate value-based healthcare in a system where we just can't keep doing the same thing and expect things to get better. So I will just leave you with some of the references, but thank you so much for your time and for the chance to share that with you.
Thank you, Mai. That was absolutely compelling and stunning. Thank you. What an amazing argument and talk. I'm struck by a few things, and I invite people to put their questions in the chat, actually in the Q&A, please. But it feels to me that probably, and I think at some point you said that there's, dignity and value is assured across the system. That needs to be the sort of the tenet of all things thereafter. And I feel like that's probably something that everyone, patients just assume is the case. And so then the action is on what treatment can I have because this is all given. But I wonder if that's a sort of a tenet or an assumption that needs to, if not challenged, at least it needs, constant reminding that that's, needs to be assured. And I'm sorry, I'm just going to follow that up with I am mindful that on one of the early palliative care studies, which was for people with acute myeloid leukemia who were having transplants, and some got randomized to palliative care and some had usual care. And the people who got randomized to palliative care had some improved outcomes, including less PTSD. And it was just sort of almost a throwaway thing. And I thought, gosh, people are getting PTSD from their treatment. So anyway, I guess if your comment initially on that, if you don't mind, and then I've got some questions.
Thanks, Ben, and a really insightful question. And it was really interesting when we were doing a lot of the key stakeholder investment early on to try and inform, how we built the model for the social return on investment. And what was telling was when we asked people about this issue of what was important to them, if they'd had that experience where care had been dignified and equitable, and they felt that it had, a really respectful relationship, it was almost silent in their interviews. But when it hadn't been there, people were really able to say what the impact that had had on them and how uncared for they felt. And what is interesting, and we published another paper from the qualitative data, where what was quite startling was people were making decisions to disengage with care and treatment as a consequence of some of those experiences. Now, not lots of people, but, the decision to stop coming for treatment that could potentially, either cure you or prolong your life because your interaction had been poor is pretty startling, and is something I think that you're right, we need to, be paying attention to.
So it's an interesting thing, isn't it? Is how do you prioritize something that's evident predominantly in the omission, or when it's
absolutely
very interesting. One of the questions from Dr. Das is around advanced care planning issues, and whether that's something that you've had experience or was brought into the some of the discussions that you were having with your social return on investment study.
Yeah, thank you. We did. It wasn't something we specifically set out to include, and it's a really interesting question, because I think if we were doing it now, and even though it was only 2017, 2018, I think it would have been front of mind. People did talk about it and talked about the importance of, probably more in that context of shared decision making and having a voice and having that sense of control. It wasn't explicitly put in to the model in terms of the return on investment, but I think it was implicit there in that sense of shared decision making, and the ability to feel that you have had an opportunity to know what is available to you, and to have those conversations, and have those conversations early on and repeated.
Yeah, thank you. Anna Keedwell's asked if we can make the references available again, and we can perhaps email them to people or put them online on the Palliative Nexus website. That's okay, Mai.
Yes.
Jerry McDonald has raised the issue of this notion of social return on investment, and it's obviously a powerful argument. And her question is, are governments, philanthropy and funders ready for sort of thinking about this, and can we frame it so that it's an essential and a given rather than a nice to have? So I guess comments for that, please, or your response.
Yeah, thanks, Jerry. Great question. And I think in the philanthropic world, absolutely. And I think, outside of healthcare, interestingly, or perhaps in a broader perspective of healthcare in the community, using social return on investment around programs like social prescribing or, community programs is quite common. And I think as an acute system, we're quite slow to come to it. I think for funders, there would be a real interest in it. I think the dose limiting factor at this point in time is it's a complex methodology. It's very time consuming. But actually, I think my sense is, having had the experiences of having to have a very steep learning curve with a methodology, is that it actually does talk to really genuine co-production and co-design of systems that, frankly, we just can't put off anymore, to understand, if we think about policies like better at home and safer at home, there has been no social return on investment profiling around those kinds of things. And we really need to understand what does value in the context of those kinds of conversations mean. So I think perhaps people aren't ready, but I think if more of us engage with these and can generate this kind of data, hopefully it'll become more compelling.
Thanks, Mai. And the last question from Lahini Wijayaratne from Sri Lanka, and touching on, also thank you for this fascinating presentation. And is there research into what family members also consider value-based care?
Yeah, what a
And
great
what the
question.
impact of this would be? And this feels particularly, I guess, in all parts of healthcare, but in Palcare, where also deeply engaged with family members.
Yeah. We did have some family carers involved in some of the conversations. We, and really included their perspectives in what some of the things were for them, particularly the burden of, bringing people for appointments and, trying to coordinate conversations and those kinds of things. But I think, that's a really important question, and I think would be a really valuable piece of work to do, giving due consideration to their perspectives as a group on their own. So thank you. I think I'm not aware of work that's done in social return on investment with carers on their own, but it would be fascinating work to do, I think, and important.
Yeah, thanks, Mai. I think we're just about at time, so it's my I just wanted to, I guess, add my thanks and my claps to all the claps that went up on the Zoom process after you finished, Mai. It was a tremendous presentation, very provocative and challenging, and such a great potential for us to sort of think about how we do things, and to think about, I guess, the language that we use as well, because I don't think we've been very good in palliative care, and I suspect in supportive care as well, is just reprioritizing that whole aspect of care within the whole, and what that really means and what the impact of that is. So thank you for a tremendous presentation. Thank you for the team behind today, particularly Kylie and predominantly also Tanya, who organises us all and gets us going, and make sure that the recordings are done and are up online, usually within the next week or so. And just to let you know, heads up, that our next Perspectives is on the 29th of May. And if I could finally say thanks to you, the audience, for coming along today, and great to have you back in the whole new year, and onwards and upwards, everyone. So thank you for being part of the session, and we look forward to seeing you at the next one. Okay, good night, everyone.